Welcome to Healthy Living. I'm Lori Johnson. Thanks for joining us. Today we're talking about hospice care, end-of-life care, what it is and who it's available to, and also why so many people who have enjoyed the benefits of hospice care wish they had started it sooner. My guest is Jessica Pope, the administrator of a hospice care center called Trinity Care, which has offices in Virginia and also Texas. Welcome, Jessica. So great for you to be here today.
Thank you for having me.
So we should also mention that you are a registered nurse specializing in hospice care.
Yes.
And so what does that involve exactly?
So I'm a registered nurse within the Board of Nursing with the state of Virginia, but I also have my certification for hospice and palliative nursing on top of that registered nurse license. So it's a special testing, special training focused on hospice and palliative care medicine.
So you mentioned hospice care, and then you also said that phrase palliative care. We've also heard another phrase, comfort care, and a lot of people aren't sure what the difference between these things are. We all know that they often have to do with end-of-life care. Can you briefly explain the differences between hospice care, palliative care, and comfort care?
Okay, I'll start with comfort care. Comfort care is a term. It's not a benefit considered Medicare covered. It's a term, you know, we keep our loved ones comfortable. So comfort care has become a term that's easy to access. Palliative care is covered in the hospital 100% under Medicare within the hospital. A lot of our local hospitals have palliative care teams and they are excellent. So hospice care comes into play under the Medicare benefit when the patient is ready to go home or wherever they call home. That doesn't have to be a residence. It could be a long-term care facility. It could be an assisted living facility. It could be a private residence. We also have a lot of private adult communities where patients reside and they can have hospice care there as well. And then there's a small segment that do receive hospice care in the hospital. So that's a Medicare benefit covered under Medicare 100%. And that's a difference. Palliative care has a different funding level. In the hospital, it's covered 100% under their hospital benefit. When they go home, if they have palliative care, it's under Part B. And there's some different funding levels with that. And it's nowhere near as comprehensive as hospice care.
All right, so the big takeaway there is hospice care is 100% covered by Medicare, and it covers a wide range of things, whereas palliative care, not so much. It kind of depends on where you are and what you receive. So that's a big takeaway. You know, with hospice care, there are a lot of misconceptions, and that word hospice sort of frightens a lot of people. It almost reminds me of people who want to maybe draw up a will or are thinking about, you know, their final resting place, buying a cemetery plot. A lot of times people don't even want to think about it because they don't want to think about death. Right. So they really don't give hospice care any thought until they're faced with their own death or the death of an immediate family member. Why should people talk about hospice and think about hospice ahead of time?
So Medicare says in order to be eligible for hospice, you have to have a prognosis of 6 months or less to live. Oftentimes, people access hospice in the last weeks of life or even days of life. Medicare is saying it should be accessed in the last months of life. So none of us are God. None of us can predict, you know, when someone is going to die. Like, we don't have a ticker that says at 6 months, it's time. So what we have to do is look at our loved ones with these chronic illnesses. They're on a declining pattern. They're not getting better. They may or may not have tried aggressive treatment and it's no longer helping. We look at quality of life versus quantity of life. So our physician, Dr. Jason Evers, he's our medical director, and every hospice has to have a medical director. He looks over the records of this patient. Where were they 6 months ago? Where were they a year ago? Are they on a declining pattern? And then our nurse does a full comprehensive evaluation. It has to be an RN or a nurse practitioner doing that evaluation. We present that information to him, and he says, okay, looking at this patient could possibly pass in 6 months or less. Now, that journey is the patient's. That's not our journey. So sometimes they live longer than we expected, and sometimes they go sooner than we expected. But that hospice benefit is so comprehensive, that's where it's different than palliative. There's a whole spiritual side of that, a whole, not religious, but spiritual side that palliative doesn't address. Palliative keeps the patient comfortable. We can do that with medications. Any nurse really or doctor knows overall what to do to keep a patient comfortable. But when you go into hospice, you start with the spiritual side. Because in my opinion, more than half of the dying process is spiritual.
When you talk about that Medicare covers hospice for 6 months.
Yes.
What if you start hospice and the patient, as you said, may live longer than 6 months? Do they forfeit those benefits?
Right. So when a patient first starts hospice, they get 6 months of care initially without having to have what's called a face-to-face with a nurse practitioner or a hospice physician. So that's broken into 2 90-day benefit periods. When we do a recertification at 90 days, we do a full, benefits discussion with that patient, with their family. Our nurse does a full report to our physician. And take note, we do this every 2 weeks on all of our patients. We go over all of our patients, their declining pattern, how they're doing, whether they're still declining, and our doctor determines they're still eligible. So at 6 months, our nurse practitioner or our physician has to go in person or virtual because of COVID and see that patient. And they have to set eyes on them. They have to review all of their medications, where they were 6 months ago. Are they still declining? If they still have a chronic illness and they're still declining and not receiving aggressive treatment, per Medicare guidelines, they are still eligible. And their care continues. It does not just stop.
But it sounds to me like that's really not what happens. Usually what happens is people start taking advantage of hospice way too late. And probably because a lot of people have 2 main misconceptions. Number one, that they think hospice hastens the dying process, which is actually the opposite is true. Research shows that hospice actually prolongs life. And number 2, there's a misconception that hospice is all about giving morphine and, in many cases, too much morphine. Can you address both of those misconceptions?
Yes. So as far as hastening the dying process, I tell our families often, hospice isn't causing your loved one to die. Your loved one is dying, so they need hospice. They need the support of hospice, but so do you. Because we're not just supporting our patient, we're supporting their loved ones, their caregivers. If they live in a facility, we're supporting the facility staff. They're getting all of this comprehensive support that they need because they are dying. As far as the medications go, at Trinity, we do a lot of education up front. Morphine is actually a very gentle opioid if it's used correctly. Our hospice physician oversees all use of all of our medications. So morphine actually helps with pain. We all know that. We see it on TV. We start all of our patients on a very, very low dose of morphine. It's usually a liquid morphine, so it kicks in really quickly. It absorbs in the mouth and the oral tissue. So we use that medication at a very low dose, and we increase it if they need it. One thing that makes morphine special that most people don't understand is, especially in the elderly, but also people with chronic illnesses, the muscles around the lungs start kind of tightening like a girdle almost. So imagine trying to breathe and someone is squeezing your ribs. It's painful, it's difficult, and if you're weak already, it's really hard to get that deep breath in. Morphine relaxes smooth muscle, so it helps those muscles relax so your loved one can take a big deep breath. It also extends the life of oxygen, so oftentimes you think morphine's going to make your loved one feel sleepy and drowsy and sedated. A low dose of morphine will actually give them energy. So then they get milestones, they get moments with their family. They have events that are planned or families coming over for a Christmas dinner. They can take their medication as prescribed, as monitored by our nurses and our physician, and they can have a good day. Every day may not be good, but those moments in hospice count for a lot.
I know a woman who died the Tuesday after Easter, and she was on hospice care, and on Easter Sunday, she had her whole family there, and she was happy. There were pictures of her with her family, and it was really just remarkable that she was 3 days away from death, but it was because she had that right balance of medication that she was able to feel good that day.
We use a variety of medications. We usually revert to morphine for our pain control because it is gentle and it is easy to regulate. It's out of the body very quickly. So if someone feels like they had too much, normally it releases the body very quickly. So we use morphine for pain oftentimes and breathing. We also use medications like lorazepam. So at the end of life, the body can kind of fight the process a little bit. I don't know if you've ever had restless leg syndrome.
Thankfully, not yet.
Right. So it's not a fun way to try to go to sleep when your
I've
legs
seen commercials about that, though. Yeah.
So there's something at the end of life called terminal agitation, and that can happen. And lorazepam relieves that so the patient can rest. Their legs aren't all over the place, and their body will just relax. Now, it doesn't hasten the process. It keeps the process from hurting the patient. Now, if we start hospice in that last week, those things are happening. We haven't had time to bond with that family to earn their trust, for them to understand, like, this is going to happen. We need to prepare them. And that's where the spiritual part comes in, because preparing the family is as important as preparing the patient. And you need time for that. And that's why Medicare says 6 months or less, because they know that time is so, so important to ensure that that last week or that last 10 days, that last month is valuable and appropriate for that patient.
Yes, this is why it's so important to educate the general public, because they should start taking advantage of this before it's too late.
Right.
We're going to take a quick break and be right back with Jessica Pope. We're talking today about hospice care. Stay with us. Welcome back to Healthy Living. We're continuing our discussion with Jessica Pope, who's the administrator of Trinity Hospice Care. And, you were talking about some of these medications that, if administered properly, as your trained hospice workers do, they can really be such a blessing for the patient, give them such relief and energy in many cases. But you were talking briefly also about the spiritual element and how you're there spiritually for the patient and for the family. Can you talk a little bit about that? What that's like to be a spiritual counselor to someone who's dying?
Yeah, so all of our patients have a full set of staff that they have access to just by electing the hospice benefit. So every patient gets an RN. At Trinity, we do an RN visit a minimum of once a week. Medicare says once every 14 days, we do once a week. We need to be there for our patients and their families in person. So we do our nursing visit once a week. They also can have a CNA, so that's a certified nursing assistant who visits 1 to 5 times a week, depending on the level of care they need with personal care. So that's about an hour a visit. That's bathing. This is all physical care. Like we talked about, palliative care would cover nursing. Palliative care also covers social work. So our social work goes out within the first 5 days to do planning and social support. They also do counseling and preparing for the dying process. But what makes hospice special is spiritual care and bereavement. So in that first 5 days, our spiritual care counselor, we used to say chaplain, but it's not religious based. It's a spiritual visit. So if the patient is a Christian, they can address those religious beliefs. If the patient is Hindu, Buddhist, atheist, they can address the patient's spiritual needs based on what they need. So our chaplain, spiritual care counselor, coordinator, he goes out in that first 5 days and he meets with the patient and their family, and he does a full assessment to see what spiritual needs they have. Now, the dying process is physical, but there's a reason people hang on longer than the physical. So sometimes patients will be, we'll have them 10 to 14 days. They're not eating, they're not drinking, they're not responding, but they're still with us. And you look at them and you're like, why are you still with us? Why have you not passed on? Something spiritual is happening. And that could be the patient's spiritual battle, or it could be the patient needing to know that the family is okay. So our spiritual care counselor, he reaches out to the family, he reaches out to the patient's extended network and finds out, like, who needs to be here? What do we need to talk about? What does this patient need in order to pass peacefully, have closure, be prepared for what's coming next? And that could, with a Christian, it could be helping them, accept Christ, accept salvation, like those steps. With an atheist, it could just be them knowing that spiritually their family is not going to lose it when they pass. They need to know that they have that support. So the spiritual part is huge. Also, bereavement, we follow the patient's family, caregiver, loved one, whoever is marked down as bereavement. It can be multiple people for one patient for 13 months after they pass away. So we make sure they're okay. All of our bereaved get a risk level, so we know if they're low risk, moderate risk, high risk, and what resources we need to provide them to make sure they grieve appropriately, that they don't kind of get stuck in the loss of their loved one. And in my experience in hospice, and especially with Trinity and the way we prepare our families up front, our patients pass peacefully. They kind of go to sleep, And that may mean for 10 days to 2 weeks, sometimes they're not responsive. Hearing is the last sense to go. So we talk to our families about, talk to your loved one. This is your gift of time. Tell them everything you've wanted to say. Find closure. If there's someone that needs to get here, let's get them here so they can say goodbye. So we initiate all of that resolution, and then our patients pass peacefully. I mean, they go to sleep and they pass. And oftentimes their loved ones will say, I watched them take their last breath. And what an honor that is. I watched them leave and it was peaceful. And that's the spiritual part. So the pain management, the anxiety management, the breathing issues, that's all manageable. That's a physical part, but that spiritual part is what makes hospice so valuable, because you can't do that in a hospital. You know, you need time to do that. You need to have them surrounded by their loved ones. And COVID changed all that as well. You couldn't surround a person in a hospital with their whole family. You couldn't do it anymore. And to pass peacefully and to know that their family is going to be okay, they needed that.
It's a gift and a calling. I can see now why you do it and why you say people in hospice care are there, because they were called to do it. We're going to take another break and be right back with Jessica Pope, the administrator of Trinity Hospice. Stay with us. Welcome back to Healthy Living. We're continuing our discussion with Jessica Pope, who's the administrator of Trinity Hospice, talking about really what a wonderful benefit it is. 6 months completely paid for by Medicare, and you offer so many services. And we were talking just before the break about the spiritual services and how you're there for people. And a lot of your clients, patients, families are Christian. Have you ever seen people on their deathbed accept Christ?
Yeah, I've seen it often. I actually have a nurse who is a very, very strong Christian, and she'll tell our patients, if you open the door, I'll walk through it. And that's what she means. If you want me to pray for you, ask me and I'll do it, because we can't push our beliefs on anyone. So if they are open to that, we will have that conversation with them. But those last days of life, you watch people come to terms with a lot of things. And so, yes, I have seen oftentimes people accept Christ, you know, come to salvation. I've seen that over and over and over again. And I think oftentimes people do it even if it's not verbally. You can kind of see the peace that comes over them. And I imagine, I mean, in my spirit, I believe that you get that time to hopefully make things right with your maker, and whatever you believe is your faith base. So it's such a privilege to watch someone's last days and to support their family through it and have them by their side. People pass how they want to pass. So I tell our families all the time, because you left the room to use the restroom and they passed away, that's how they wanted to do it. Maybe they didn't want you to have that memory. Like, it's how they want to pass. The person in the room with them is who was meant to be in the room with them. If they weren't there, then that's how that was meant to be.
What are some of the things that you've seen? You've seen so many people pass on, and you're a very strong Christian. What are some things that have affirmed your faith towards the ends, like some of the things that your patients have seen and said and done?
So it's interesting. Oftentimes, people will see people who've already passed. And I've lost some family members that are very, very close to me. And it gives me peace knowing I truly believe that someone you love, someone that's gone ahead of you that you trust, will walk you over. You won't be afraid. Oftentimes people are not afraid when they pass. They've either just kind of gone to sleep or they just release. And in those last days, it's not uncommon for people to see maybe children they've lost, parents that have gone ahead, close friends, close family members. And that alone to me has totally affirmed my faith. I know that my loved ones are waiting for me.
Have you ever seen or heard people talking to God or Jesus?
Oh, we had a family that the patient was speaking to Jesus as if he was right there, right in front of my nurse. And I've had nurses often say, I could feel angels or spirits or you know, I don't know if they mean Jesus or God or whoever is affirmed in their faith, but they feel them right there. So, oh yes, oftentimes we'll pray with patients, or we'll do whatever we can spiritually and whatever they're comfortable with. We just facilitate the process.
All right, we're going to take one final break. This is so interesting and also very encouraging. We'll be right back with Jessica Pope. She is the administrator of Trinity Hospice Care. Stay tuned. We're continuing our discussion with Jessica Pope about hospice care, and what's so great about hospice, a lot of people don't realize, is how much is covered. You know, so many things that are expensive out of pocket are 100% paid for through the hospice benefit and Medicare. Can you kind of go over the main things?
Yeah, so we cover all the services we talked about. Our social workers step in that first 5 days as well to help families access resources they may not even be aware they're eligible for, or they may need to access in order to get the care for their loved ones. We cover all of the medications related to the hospice diagnosis and any symptoms that need managed. All of that is paid for. We give them a little pharmacy card and they go and we pay for that. And we cover equipment. So if your loved one needs oxygen, we don't have to jump through hoops to get oxygen. We put that in the home. We can do hospital beds, low air loss mattresses if they need them, wheelchairs, any medical equipment that is needed, we can put that in the home as well. And it's all covered. There's no copay. It's covered 100% by Medicare. And most private insurance companies for those under age 65 have a hospice benefit carve out that is usually pretty comprehensive.
So how can people get hospice? Does it have to be ordered by a doctor?
So 2 physicians have to determine that the patient is certified to be terminally ill. And so they can ask their PCP. If they are in the hospital a lot, they can ask the hospital physician. A specialist, they can say, we would like a hospice evaluation, and the physician just sends us an order for hospice to eval and treat, and then our physician is the second doctor to sign off.
And so many people, the doctor says, you know what, I think you should think about hospice, and the family says no, or the patient says no. Really, they should at least have a consultation. They don't have to accept it. They can at least just find out about it, right?
Right. So if your physician has identified that you need hospice, that conversation is important because they're saying you need a higher level of care. You need more support. And what you have right now is not enough. So whatever level of care your loved one is receiving, it's not enough. They need more. And that's why the doctor is recommending hospice.
Well, this is fantastic information. It's something that we all need to face, something that we all need to know about, and it's an incredible blessing, and that a lot of people don't realize. So how can people find out more about Trinity Hospice, your company, or hospice in general?
So our company's website is www.trinityhospice.com. Pretty easy. And then hospice in general, there's, Medicare.gov has a whole section on hospice, what it means to be eligible and how to make sure your loved one is compliant within hospice.
All right. Well, Jessica Pope, thanks so much for being here today. It was great for us to learn all this valuable information. Thank you for the work you do.
Thank you so much. I appreciate it.
And thanks to you for joining us for this edition of Healthy Living. I'm Lori Johnson, and we'll see you again next week. Bye now.